A 26-year-old woman suffers from heaviness in her swollen left calf. In horizontal supine position, echodoppler shows a left common iliac vein occlusion compressed by the right common iliac artery against the lumbar spine. Here is the blocked flow and the dilated left iliac vein. Semi-seated position spreads the right iliac artery and releases the flow, so no more May-Thurner syndrome. Here is the left iliac vein liberated. The flow is normal. Posterior tibial vein pressure measured by echodoppler was normal and symmetrical, 20 mm of mercury in semi-seated position. So, postural May-Thurner syndrome was clinically and hemodynamically asymptomatic. Echodoppler shows a gastrocnemian venous malformation, then treated because it was the real responsible for heaviness and swelling. Echodoppler shows a gastrocnemian venous malformation, then treated because it was the real responsible for heaviness and swelling. Differential diagnosis between true and postural pseudo-May-Thurner syndrome. If in supine, horizontal echodoppler and venography show a total occlusion of the left common iliac vein, is it a true or a pseudo-artifactual May-Thurner syndrome? Yes, if the occlusion persists in semi-seated position. Iliac vein is still blocked, so it's a true May-Thurner syndrome. No, if the occlusion is released in semi-seated position. If semi-seating liberates the compression, that means that it is a pseudo-May-Thurner syndrome, but not a true one. So far, scholars thought that the natural frequency of compression of the left iliac vein and its clinical significance in asymptomatic disease has not been established. In fact, the significance was not established due to the postural artifact of the CT scan, MRI, and venography performed only in supine horizontal position. Now, echodoppler in semi-seated position can establish it because it can be easily performed on supine and semi-seated position. This explains why postural MTS is asymptomatic, because people do not live all day lying horizontally their back. As long as the repeated postural compressions, particularly during the pregnancy, and endovenous anomalies triggers a thrombosis as confirmed by the prevalence of left iliac vein thrombosis, particularly in pregnant women. As we have seen in this example, a properly performed echodoppler can relate symptoms to their causes and avoid overdiagnosis and overtreatments. Indeed, overtreatments can be also avoided in a true MTS and left iliac vein thrombosis if the PTV pressure is normal, which attests for a correct collateral compensation, as in the following example. Doppler pressure of left posterior tibial vein is 20 mm of mercury. It attests for a compensated left common iliac vein occlusion. If PTV pressure is normal and symmetrical at both ankles, at rest and stress, the signs and symptoms cannot be due to any consent obstruction, despite the static scan, MRI, and venography data. Here, signs and symptoms can be due to other causes as valve incompetence, as in some post-thrombotic diseases where incompetence and occlusion are associated. Nevertheless, stenting is, despite its rate of complications and long-term anticoagulation, is a revolutionary treatment, but only in cases of insufficient compensation of the left iliac vein occlusion. Perhaps these patients should not lie supine horizontal to avoid crushing the stent and possibly compress and stenose the right iliac artery, as in the following case. In this example, the right common iliac artery is stenosed by the stent of the left iliac vein. Hippocrates should still inspire us. Thank you for the attention.